Hey everyone, Dr. David Clark. Today I'm going to walk you through another real patient case study from my office. Today we have a 33-year-old woman with Hashimoto's, already diagnosed, infertility, trouble getting pregnant, stomach pain, and hair loss. Now, this case began with the email that you see here from her husband. He says, my wife is 33 years old, suffering from Hashimoto's hypothyroidism, diagnosed 18 months ago. She was taking levothyroxine, but recently switched to Thyroid. She's still not okay, having lots of adrenal issues. We'll talk about that. We want to have a baby, but we're not conceiving naturally. And their first child was born after taking Clomid or clomiphene and has severe autism. So let's just jump right into this. So she can't get pregnant. The first child was conceived with clomiphene, and yes, the child is autistic, and we can talk about what the connection might or might not be. So what we know is that despite their natural efforts, they're not able to conceive and get pregnant. Stomach pain and burning and burping. And I'll just tell you, anytime I know that someone's got Hashimoto's and I hear that they've got stomach pain, my first thought is they probably have a stomach autoimmune problem, but we'll test and find out. And then last, she has irregular periods, irregular cycles, and heavy periods, which could have something to do with why she's not able to get pregnant. So if we kind of start with her history, at 13, she had absence seizures. At age 20, those seizures were under control, taking medication. She still takes that medication at this time. At age 24, she had the onset of hair loss. She was diagnosed with an anemia, irregular menstrual periods, constipation, and weight gain. Now, I don't know what kind of anemia, but I would assume it was an iron anemia. Hair loss could be because of a thyroid problem at that age, could be because that her iron was low. Something you may not know is that if your ferritin is less than 70 in a woman, that is a risk factor for hair loss all by itself. But of course, one of the kind of classic signs of hair loss, and I have other videos on that, in Hashimoto's, of course, you can get 3 different patterns. The classic one is a diffuse hair loss, which I believe is what she had. And she may have been having these Hashimoto's symptoms back then. And that's not unusual for a person to have Hashimoto's for 7 to 10 years before they finally get tested and diagnosed with it. Now, at 25, she took clomiphene and conceived her first child, as noted earlier. That child's now 8 but has autism. At age 30, she was diagnosed with Hashimoto's due to elevated thyroglobulin antibodies and prescribed levothyroxine. So just to remember, Hashimoto's, of course, is an autoimmune thyroid condition, and the 2 tests that will tell you if you've got Hashimoto's, or the antibodies, are thyroid peroxidase antibodies and thyroglobulin antibodies. Some doctors, for some reason, won't run the thyroglobulin antibodies, but you miss a lot of people who have them. All you got to have is one to have Hashimoto's, and of course, there's a spectrum. There's euthyroid Hashimoto's where you have the antibodies, but the TSH and T4, T3 are normal. There's subclinical where you have the antibodies. The TSH is high, but the T4, T3 are normal. And sometimes, depending how bad the TSH is, you will or won't get prescribed medication for that. And then lastly, there's overt hypothyroidism, or just plain hypothyroidism, or Hashimoto's hypothyroidism. And that's, of course, when the TSH is high, the T4 or free T4 are low, and you have the antibodies. Now, I will tell you that most people that have subclinical Hashimoto's, if they don't do anything, I shouldn't say most, a lot of people with that are going to end up getting overt hypothyroidism because they don't know that they have it. And this lady, of course, she was diagnosed due to elevated thyroglobulin antibodies. She took iron, vitamin D, fish oil, selenium, curcumin. I mean, all that's pretty good stuff. And those seem to help the hair loss and the irregular periods and the constipation. Now, of course, her irregular menstrual periods could be due to the thyroid problem she was having, and the constipation could have been due to the thyroid problem. So also remember, just since we get started here, there's basically 2 kinds of thyroid problems. There's a quantity problem, and then there's what we call a usage problem. Hashimoto's will create both because the antibodies help destroy the inside of the thyroid gland, and so you can't make thyroid hormones, and that creates a quantity problem. But it also creates a usage problem. I think that's very important to know in this case. The usage problem means that, blood tests can tell you how many thyroid hormones are floating around or how many thyroid hormones you're making or taking, right? But it can't tell you if you're using them. Using them is a function of your thyroid hormone receptors, and those are inside the nuclei of all your cells. But we do know from research that's been done that those receptors, what happens is they're kind of like they're waiting for the T4 to come by and dock, the T3 to come by and dock and tell the DNA of that cell what to do. But those little receptors can be blocked and blunted and just kind of generally made to malfunction so that you could have normal looking labs but not be functioning like they're normal. I hope that makes sense. I have some other videos that help explain that. All right. So at age 31, they tried to increase her levothyroxine as well as trialing cytomel, which is T3 by itself. Levothyroxine is T4, which has to be converted, and cytomel is T3, which doesn't have to be converted. However, that produced burping, bloating, stomach pain, and a resurgence of the irregular periods and hair loss. You might say, well, how the heck did that happen? Well, they probably induced a state of receptor resistance, which means it's kind of like if you ever try to grow like a house plant or garden. You know, plants need water, but if you like overwater them, they die. Well, that's kind of the way these receptors can be. If you flood them with thyroid hormones, then they can resist and essentially down-regulate. It's kind of a self-defense mechanism. And that's not that common, I'll tell you, but it certainly sounds like that's what happened to her. At 32, she was diagnosed with low progesterone, and she's now taking Westroid, which is a porcine bioidentical thyroid replacement. Now, the low progesterone, of course, can make it very difficult to maintain her pregnancy. It can also be why her periods are heavy. Let's see what the rest of her history shows us. Now, she had a bad reaction to some supplement called adrenatone. All right, now she's taking, right now, upon presentation to me, Westroid, selenium, iron, vitamin D, B12, fish oil, calcium, magnesium, curcumin, vitamin C, niacin, B6, prenatal multivitamin containing iodine, which caught my interest because iodine and Hashimoto's typically don't go well together. And I know there's people that'll disagree with me, but beyond a certain threshold of iodine, it's a great way to give yourself Hashimoto's, and it's a great way to aggravate your Hashimoto's. The amount of iodine in a multivitamin is probably only a couple hundred micrograms at best, so that doesn't really concern me. Milligram amounts of iodine, that is concerning. But, you know, she's taking things that are generally pretty good, that have a pretty good track record, but she still has what we see here. So what in the heck is going on, right? So her family history, and we always care about the family history. So she's got a father with thyroid cancer. Now, thyroid cancer is associated, some types of thyroid cancer are associated with Hashimoto's. She had an uncle with hypothyroidism, and I would bet $100 that both of them have Hashimoto's if they were tested. And that goes to the point that Hashimoto's is an autoimmune condition, and it is highly heritable, but not all cases are like that. You know, you can have a genetic predisposition to autoimmune conditions like Hashimoto's, but you can also develop Hashimoto's, what I call acquired Hashimoto's, where you have an infection and there's cross-reaction, and that sets up the whole antibody thing. So excuse me, they're not all genetic. Now, in terms of her diet, she is gluten-free and mainly milk-free. And if you guys know anything about my channel, gluten and dairy are like the two worst offenders when it comes to foods you should not be eating if you've got autoimmune problems in general. Now, with Hashimoto's, it's a little bit different. I don't want to get too detailed, but she has thyroglobulin antibodies, and we don't really know of any food cross-reactors as it relates to that, okay? She does eat rice multiple times per day. That might be a problem. We'll have to find out. She drinks tea multiple times per day. Now, again, if it's green tea, different types of herbal tea, they can skew your immune system in a way that might not be good based on your immunophenotype. And again, I'll talk about that in a minute. But immunophenotype is critical when it comes to dealing with autoimmune patients because, you know, we all have our own fingerprint, right? Even though we all have, you know, we all are humans, we each have our own fingerprint. Well, our immune systems are very much like that as well, because even though we've all got an immune system, how our immune system is put together and exactly what it looks like is unique to us, or our immunophenotype. Phenotype just means what does something look like, all right? So phenotype is really important when it comes to people with autoimmune conditions because you can take things that are supposed to be good that can skew your immune system in a certain direction that can make your immune system phenotype worse, right? So let's find out what happens with her. Now, these are some historical tests that she had available before she came in. And I'll just kind of use the cursor here. Now, you'll notice that her thyroglobulin antibodies were quite elevated before she began taking her levothyroxine and these other replacement hormones. And over time, if you look down here, they have steadily decreased, which is great. That's wonderful. But it's a perfect point to let you know that antibody levels don't correlate with how you feel, because her antibody levels have gone down and down and down, but she still has the symptoms that she's coming to me with. So don't fall into the trap of thinking, oh, I just need to get my antibodies down to 0 and I'll be fine. Not necessarily. Antibodies are one marker of what's going on with your immune system, but not the only marker. That's why it's really important to use, you know, the patient's response to the treatment as a primary outcome measure, I think. And of course, these other things are great, but Antibody levels go up and down no matter what you do anyway. So you just can't fall into the trap of just, I'm going to focus on the antibody levels, and if I get the antibody levels down, then I'll be better. Maybe, but not necessarily. We'll also show that their ferritin, now these are units, these are the same as nanograms per milliliter. 14, very, very low. Like that is not good. And she really hasn't had that retested since she originally started. And I don't like that. We're going to have to look into that and see what her ferritin's doing. Ferritin is the best test of your body's iron status. I know it seems weird because there's a test on blood work that says iron, but that's only 1% of your body's iron. Ferritin's 22%. It's the better test to look at. The problem with ferritin, though, is it also is an inflammatory marker. And so it can be elevated because you're inflamed, not because you have too much iron. I know I went through that very quickly, but I just wanted to mention it. All right, now, there's some labs that I did on her. As you can see, her ferritin's a little bit better, right? 66. CRP, which is inflammatory marker, high sensitivity, that's not elevated. And you might say, well, if that's inflammatory markers not elevated, then she's not inflamed. No, not exactly. I mean, CRP is 1, or high sensitivity cardiac CRP. That's one inflammatory indicator. It's not the only one. So don't fall into that trap either. I teach a lot of doctors this stuff, and of course see a lot of people that have seen other doctors. And a lot of doctors fall into this trap of, A, not recognizing that ferritin that she had earlier, that like 14 is terrible, even though it's within the reference range. They fall into the trap with ferritin that they don't realize that ferritin is also an inflammatory marker. So if someone's ferritin's 150, but the other iron markers are normal, their iron's not necessarily high, it's probably because they're inflamed. Now her A1C is normal, blood sugar's looking okay. All of her thyroid numbers are looking pretty good, which we would expect because she's taking thyroid hormone replacement. Now this free thyroxine here, her free T4 is slightly low, but that's not that big a deal. Free T3 is normal, etc. Her vitamin D, 158. Again, these are different units that you're probably used to seeing. That's fine. But look down here at her antibodies. Now her thyroid antibodies are normal using this analytical method. And that brings up a point I want to share with you. You can't compare antibody results from one lab to the antibody results from another lab unless they use the exact same analytical method. You can see here it says method used for this, Roche modular, the method used for this, Roche modular. Well, not all labs use that. So you got to be sure that if you're comparing your antibody levels from one point in time to another, that they're using the exact same testing method. But you can see here with hers that her thyroglobulin is normal, although not 0, and her thyroid peroxidase antibodies are normal but not 0. And that's not a big deal because we all have these different levels of antibodies, and as long as you are, some antibodies are normal, I guess is what I'm saying. It's how your immune system kind of surveils things. So it's not that we want antibodies to be 0, we just don't want them to be elevated beyond a certain threshold, right? And for her, those look pretty normal. So does she still have Hashimoto's? Well, Hashimoto's can't be cured, right? So technically speaking, I would say she probably still has Hashimoto's, but right now the antibodies are negative and she is euthyroid, E-U-T-H-Y-R-O-I-D, which means that her numbers look pretty good. But look at what we found. Remember she had this stomach burning, and I told you at the very beginning of the video, I said, anytime someone's got an autoimmune problem and they have stomach burning, my first thought is they have a stomach autoimmune problem. Well, we tested for that. And we tested gastric stomach parietal cells. And parietal cells are these cells that line the stomach, and she's got antibodies for those. Now, what is interesting about those cells is they produce not only intrinsic factor, they produce the mucus layer that lines your stomach. And so when you get antibodies against these that are directing attack and destruction, you start to lose the ability to make that lining. And so the stomach acid you make can now affect and touch your stomach lining. And it's a pretty bad situation. A lot of people that have this have very just like unrelenting stomach burning, almost like heartburn, but it's like in your stomach and it doesn't go away. And another good point about this is when you've got one autoimmune problem, the odds are you're going to get another one because a taboo has been broken in your immune system. It's basically your tolerance for yourself has been broken. So it's just a known phenomenon that if you've got one autoimmune condition, unless you do something and do it very quickly and consistently, you're probably going to get another one. So anytime I see someone that's diagnosed with Hashimoto's and probably had it, 9 years ago, I'm pretty sure they're going to have additional autoimmune problems, and that matters a lot to treatment, okay? Because yes, there's lots of different kinds of autoimmune conditions, They all get different names based on what's being attacked, and biochemically they're all very similar. But we now know that there are foods that if you eat them can cross-react with these antibodies. What does that mean? That means that they can make the autoimmune attack on these tissues worse. So it's really important to know what antibodies do we have. So what did we find out? Well, the other thing I want to mention is also what can happen in Hashimoto's with stomach burning is you can also have what's called a Helicobacter pylori infection. And we have to check for that. So let's see what we found. So anyway, to summarize this slide, thyroid antibodies negative, I talked about that. But she definitely has stomach autoimmunity with these gastric parietal cells. Now, the other type of thing we did with the blood work was look at her follicle-stimulating hormone, her luteinizing hormone. They're pretty normal. There's not much going on. Carbamazepine is the anti-epileptic medication she's taken, and that's fine. So fairly normal looking on this stuff. But we did what's called an H. pylori breath test, and that's a really easy test you can do to see if someone's got H. pylori. You can also do blood antibodies. You can do stool antigen tests. This has got a pretty good sensitivity and specificity. It's very simple to do. You can't do it if you've been taking antacid medication. But guess what? She has H. pylori. Now, H. pylori, as a bacteria, cross-reacts with these parietal cells. So I've used that word cross-react a bunch of times. Now, what does that mean? It means that the antibodies that your immune system makes for one thing can stick onto another thing, right? And that's what happens with H. pylori. You can have H. pylori that then morphs into gastric parietal cell autoimmunity. Or you can get what's called a thyrogastric syndrome, where it starts with Hashimoto's, and then you get the gastric parietal cell antibodies. It doesn't really matter in terms of, what our treatment's going to be, but we know that it does happen. So anytime someone's got stomach pain, we probably need to check and see if they have H. pylori, because it's a pretty simple test to do. Well, we're going to have to get rid of this pronto. All right. So he's got the H. pylori infection. Now, we also ran the multiple tissue antibody testing. Now, what did we find? Now, look, there's a whole bunch of things here, right? I mean, there's an incredible number of things here. So anytime you see this number of antibodies, you know something's going on. She could have a viral infection, and she has what we call a polyreactive antibodies. She could have, sometimes there's molds that can do this. She doesn't particularly have the one, she doesn't really have evidence of that on this. And sometimes there are foods that are cross-reactive with multiples of these tissues, and it's the food that's driving what you see here, okay? So just look, we have parietal cell antibodies, right? Well, we already know that. We knew that from a different test. So we have two different labs telling us, oh yeah, she's got parietal cell antibodies. She's also got out-of-range tropomyosin, which is an intestinal antigen. Thyroglobulin, we already knew that. Again, you see the thyroid peroxidase was negative, but the thyroglobulin wasn't. Alpha-myosin is something you find in heart. Phospholipid is something you find, this is actually cardiolipin, which is one of the phospholipids. You find that in all sorts of different cells, but I'll tell you that phospholipid antibodies, particularly this one, I don't like those because they promote a prothrombotic state, and it can predispose you to miscarriages. They can also cause patchy hair loss. Now, I neglected to up here show you guys, I didn't circle intrinsic factor, I didn't circle ASCA and ANCA. Intrinsic factor is a stomach-based antibody. It's what these parietal cells make. It can make you B12 deficient over time. ASCA and ANCA antibodies are intestinal antibodies associated with things like ulcerative colitis and Crohn's disease. Now, moving on down the list, she also had ovarian antibodies. Now, wait a second. That could have a big explanation for why she has these weird periods, right? Because she could be getting, just like you can have thyroid autoimmunity and you can become hypothyroid, well, you can become hypogonadal or hypo-ovarian, right? Meaning she may not be making hormones when she's supposed to. Because, I just showed you the FSH and the LH, and those looked pretty good. But I'm telling you that ovarian antibodies are also something that are very important, potentially in her case, having the infertility. If we go on down, she had insulin and islet cells. That's a type 1 diabetes marker. She also had glutamic acid. I don't know if I circled these. Yeah, she also had glutamic acid decarboxylase, which can be a type 1 diabetes marker by itself. Myelin basic protein, myelin's in myelinated central nervous system neurons, often associated with demyelinating conditions. We don't really think she has one of those based on her symptoms. But look at all these antibodies, right? You're just like, oh my God, what's going on, right? And then lastly, she had alpha and beta tubulin. Now, you do find those in some Hashimoto's patients. You also find it in people who have basal ganglia autoimmune. So look, there's a bunch of stuff here. The thing I want you to know is, that she's got stomach autoimmunity, intestinal autoimmunity, thyroid autoimmunity, heart, ovarian, pancreas antibody, myelin. What do we do with that? Well, I can tell you that I know the foods that cross-react with those different antibodies. And essentially, she's eating those foods, okay? So we're gonna have to do some things with her diet to eliminate those cross-reactive foods and see what happens. Now, in terms of her phenotype, well, we already know there's an autoimmune phenotype, right? But we did not have, at the time I saw this lady a few years ago, we did not have the lymphocyte map. So there was a different way that we did it that I'm not even going to explain, but basically her Th2 cells were high, we thought, right? So we don't want to do things to boost that. We want to do things to control that, right? To regulate that. All right, so what's the treatment plan going to be for this lady who's got Hashimoto's? She has infertility, meaning she can't get pregnant. She had to get pregnant with clomiphene the first time. She has the stomach pain, which she has H. pylori. She has hair loss. What are we going to do? Well, number one, we've got to eradicate the H. pylori, and I'd like to do that. You can do that a couple different ways. There's certainly like medications and antibiotics you can use, but she didn't want to do that. And so there's a very effective kind of botanical thing that I've used for a long time that works great. Takes about 60 days, but it does work great in about 98% of cases. I'm going to put on a short-term anti-inflammatory repair diet. And again, you guys don't try to, I can't tell you exactly what I did because, that wouldn't be really ethical because what you need might be different. But she's going to avoid all those cross-reactive foods that I was alluding to, like all those different antibodies. She surely can't have all those antibodies really, right? A big chunk of those are being provoked by the foods that she's eating that cross-react with that, right? And we're also going to put her on an anti-inflammatory immune regulatory supplement protocol because she has an autoimmune problem. We already know that, right? She's got two of them for sure. I think two of them. She's got the Hashimoto's and she's got the gastric parietal cells. Although, the antibodies that she did from the ones I showed you where they were normal, but on the Cyrex they were positive. It shows you that labs use different ways to measure them, right? So let's see what happens. So we do that, and 30 days later, she says, my stomach pain's 90% better. Now, it's either 90% better because we're eradicating the H. pylori, or it's because we're de-inflaming and kind of down-regulating that gastric stomach autoimmune problem. The burping's 90% less often, and that actually brings up a good point. People that burp a lot, especially, 10, 15 minutes after they eat, it's usually because they don't have enough stomach acid. So gastric parietal cells and H. pylori mess with your stomach acid levels. They can erode that mucus layer that protects you from stomach acid, but also decrease your production of stomach acid. And burping, especially 10 to 15 minutes or so after you eat, is a pretty good sign that either A, you swallowed a bunch of air, or that you've not got enough stomach acid. Now, why you don't have enough stomach acid, there's a bunch of different reasons for that. But in this case, it's because she has H. pylori and she has gastric parietal cell antibodies. But this is 90% better after 30 days. The hair loss is decreased, the sort of diffuse hair loss, the classic kind has been decreasing, which is great. She says her energy's improved. That's wonderful. She's not pregnant yet because they're trying and checking. And what do we do now? Right? So she's doing pretty good. We like the protocol that she's doing. And again, I like to do my treatment plans in 30-day chunks. I think that's plenty of time in 90% of cases to find out if you're, if you're moving the needle and if that's working. So her treatment plan is we're going to do a programmatic reintroduction of foods. And that whole reintroduction is a test. It's a test of the integrity of her gut lining. It's a test of her tolerance to certain things. And it works 1,000 times better. Eliminating and then reintroducing works 1,000 times better than IgG food testing, which we could talk about forever, but I don't do that testing. It's a waste of time. But she's still going to avoid all these cross-reactive foods I'd pointed out based on her tissue antibodies. And then we're going to keep her on that same anti-inflammatory immune regulatory supplement protocol. Okay, 60 days into treatment, we're following up. What do we find? No stomach pain at all. No excessive burping, so that's gone, right? But we still need to do what? We need to recheck that breath test to make sure we actually got rid of the H. pylori. And I can't tell you how many times doctors don't do the retest. That's more important than the first test. You have to do the second test and find out did you actually get rid of it. So we'll see if we did that. Energy still improved. She might be pregnant. She missed her period, but that's happened before, so we don't know yet. Of course, I'm curious. So we are going to retest that urea breath test, which is that H. pylori test. Avoid the cross-reactive foods. We're going to keep doing the anti-inflammatory regulatory protocol and see what happens. So the breath test is negative. Fantastic. We think we probably did that, right? So that's good. Now, that may be why the stomach pain and the burping is gone. It may be that and a combination of the immune regulatory stuff. But the bottom line is we had to get rid of that H. pylori, and it looks like we did. So what happens now? Well, I get an email from her husband. They sort of drop off the radar a little bit. And I get an email from her husband, and this is what it says. It says, hey, hope you're well. We went to India for a 2-month break and are still struggling to come back to normal, kind of readjusting to life back at home. But his wife is 17 weeks pregnant, okay, and they want to book an appointment, and they also want me to help their daughter who has autism. So I started doing some math, and I said, well, obviously this is great because that was like their main thing is they wanted to get pregnant, and they wanted to do it naturally without using clomiphene. And I did the math, and I said, you know what this is? She got pregnant about 45 to 60 days into treatment. So around that time, you know, when she thought, maybe I'm pregnant, she was. So that's cool, right? So how did that happen? Just remember that, you know, she had ovarian antibodies. She had all these different antibodies. Her immune system is obviously going kind of nuts. And she was basically doing kind of the right things, more or less, with her supplement protocol, but some of those things weren't at the right therapeutic doses. The big thing with her was she was eating a lot of foods that she should not have been eating. And we know that not based from food sensitivity testing, but from the tissue antibody testing and the knowledge of what foods cross-react to that. That's what I think really did that. And by down-regulating the immune system, number one, you will make thyroid hormone receptors work more correctly. Because remember, the number one thing that will mess with thyroid hormone receptors is cytokines and inflammation. But cytokines do that to basically all receptors, all different hormone receptors. So I think that by de-inflaming her adequately and getting her immune system under control, that allowed her body to do what it wanted to do, which was to get pregnant. Now, that's awesome. Remember, she had low progesterone. I'm still concerned, okay, is she going to be able to carry this pregnancy to term? Well, let's see what happens. So we altered the supplement protocol due to her pregnancy. There's a few things she really shouldn't take if she was pregnant. It's not that they're dangerous, there's just not a lot of data on it, but we can err on the side of caution. I said, hey, you need to maintain the diet to avoid those cross-reactive foods because what we don't want to do is have you start eating things that we know are a problem, flare up your immune system, and God forbid, you know, you have a miscarriage. Well, we fast forward about 8 months, and she maintains the pregnancy and delivers a healthy baby girl, right? Which is what they wanted. So if we go back and look at that and say, okay, what did this lady present with? She had Hashimoto's, infertility, okay, gave birth to a child, got pregnant naturally, didn't need any drugs to do it. The stomach pain, that's totally gone. That was gastric parietal cells and H. pylori. And the hair loss, right? That's pretty good. Now, I share this with you, not to pat myself on the back, but to let you know this is what's possible if you work with someone who takes the time to dig and do the detective work and has a lot of experience and a lot of knowledge. So if you have Hashimoto's and infertility or some of these other things that we've talked about, or you know someone that does, make sure they work with a doctor that knows how to do the stuff that we just talked about, right? How to look at the immune system and look at these cross-reactive foods and understand how to analyze the history, because you've got to find a doctor that is current and modern and does the right kind of lab testing, knows what lab testing, what lab testing to order, how to interpret those lab tests, how to treat what we find, how to know if the treatment's working, how to follow up. So I had a lot of fun presenting this. This is one of my favorite cases just because it's a nice kind of illustrative case of all the different things that can go wrong in Hashimoto's. And it's a really nice kind of a teaching case because of all the different things that show up in this case that if you've got Hashimoto's, you need to know. So anyway, I hope you found it helpful, and I'll see you for the next one. Have a good one.